you feel is there a risk of overdiagnosis or intervention because of the technology coming in?
Yes, that is always there. A lot of people who probably can be managed by just medicines or don't need anything. They are subjected to various procedures which might not be essential. So this is a reality.
We haven't seen any real, use cases as of now as we speak about AI.
There are some errors being picked up in CT coronaries. So AI helps us in getting a more precise diagnosis. I am not aware that AI is able to predict that X is okay today and 10 years hence he is going to get a heart attack.
How much heart diseases have increased, and over the years we have seen a lot of celebrities also dying because of heart issues.
The reason is that this is an extreme. So when they are giving up on moderation and going into an extreme, whatever sort of extreme, even extreme alcoholism, extreme smoking, extreme exercise, extreme stress.
Starting with how much has cardiac screening technology evolved over the past few years, as per you?
The number of false positives and false negatives, the positive predictive value, the negative predictive value of these tests are suspect. So they cannot be mass screening tools.
Alright, joining me for this episode of the Healthy Podcast is Dr. Rajiv Passey, Senior Cardiologist at Sir Ganga Ram Hospital. Dr. Passey, thank you so much for joining us.
Thank you Hemanshi for getting me here, and it's a pleasure.
Yeah, and to our audiences, for this podcast, we are here at his turf. We are not at the basic setup. This is not your basic podcast. No warm lights, no podcast set. It is, we are where we can actually see the truth. So, Dr. Rajiv Passey, we are starting with how India is now being known as a cardiac capital of the world. Let's start with that.
Yeah,
Why?
that's one of the biggest concerns as an intervention cardiologist. The number of cases with cardiac problems has been on the rise in the last 15-20 years. This rise is reflective of the lifestyle that the Indian population is leading. The number of cases in youth, which means in 30s and 40s and early 50s, is far more than what is seen in the West. Yeah. So the pattern is something which is reflective of a bad lifestyle, a presence of diabetes, smoking, etc., which is resulting in number of cardiac cases becoming significantly more in a younger age group. And which is a cause of concern, because this leads to both increased morbidity and mortality at a younger age. So definitely India is now becoming it was the diabetic capital, now it is becoming the coronary artery disease capital of the world.
Yeah, so we'll break it down one by one. You said a lot of lifestyle changes are the reason behind this tag that we have got as a country. So how is India different from other countries in the world? What are those lifestyle changes that we follow, and perhaps we should stop right now?
Yeah, that's also very relevant. See, genetically Indians all over the world, whether it is in the US, in Europe, in Australia, or the people of Indian origin are more prone to heart disease. That is, the bad cholesterol is higher and it is more likely to cause damage. That is one. Second, the being genetically prone and having a bad lifestyle is a very dangerous mix. Yeah. So in far younger population, it is now seen that young, both males and females, who are driven by goals, who are driven by a lifestyle which includes excessive smoking, alcohol, sedentary lifestyle. All these are factors which are predisposing us to having more cardiac events at a younger age than in the Western population. Yeah. So the number of cases in the younger age group is disproportionately higher in Indian population rather than in maybe in rest of Asia like China, Japan or Korea, and even more than the Western countries.
All right, so can we, like Indian population, you're talking about genetic issues or genetic reasons. What about South Asian phenotype? Like, how much similar are we to that South Asian phenotype? The idea of,
yes,
high
exactly.
visceral fat, then BMI, I think, if,
this
even if the
again
BMI
is a
normal.
part of metabolic syndrome, which you are addressing. Metabolic syndrome is obesity with diabetes, with sedentary lifestyle, giving rise to various diseases, which the most prominent of them is atherosclerotic disease. Atherosclerotic disease can be disease of the heart. It can be diseases in the vessels which supply the brain. It can be diseases in the vessels which supply the legs, the kidneys, and so basically it is cholesterol deposition in these arteries which is occurring far more than in the West. And the factors, as I just mentioned, is that we have that phenotype. We are genetically more prone, and once it interacts with the phenotype, that is the environment, then the results are pretty bad.
Yeah, I do have questions on the complexity of cases as well, doctor. But because now we are talking about how much heart diseases have increased, and over the years we have seen a lot of celebrities also dying because of heart issues. What's the reason behind that? And of course, there was also a thing that we've seen few articles and a lot of people talking about how after COVID this has also increased. So what's the link there?
There are two parts of your question. The first is why celebrities, why people with who are more type A personality getting heart disease. The reason is that they are goals driven, they are more ambitious. The key to treatment of heart disease or prevention of heart disease is moderation. Moderation in everything. Moderation, if we have in lifestyle, in what we eat, in how we approach the various problems in life. Moderation, if we have, then we are able to even see a lot of celebrities had problems in the gym.
Yeah, exactly.
That is one.
Yeah.
Lot of them were running marathons.
Yeah, without having breakfast and all of that.
The reason is that this is an extreme. So when they are giving up on moderation and going into an extreme, whatever sort of extreme, even extreme alcoholism, extreme smoking, extreme exercise, extreme stress. See, if you have an emotional stress, if you have something going wrong in your family, in your business, in your job, all these are factors which are prone to increased heart disease. So most of these people had some stress which resulted in that particular moment, what we in technical terms call plaque rupture. Plaque rupture is the cholesterol which is deposited in the heart arteries. If it ruptures, it sort of gives rise to clot formation and blocks the artery, which can be due to any extreme. So once this plaque rupture occurs, the blood flow is compromised, the patient gets sudden chest pain, or he can just pass off. So this is what I was emphasizing, that the extreme of anything, whether it is sport, whether it is activity, smoking, alcohol, whatever, is giving rise to more problems than solving them. That is one. Second aspect is COVID. COVID also was a phenomena in which there was altered clotting in the blood. So very often we were finding patients who were dying of COVID had some clots in the body which were formed because of the COVID, the milieu which was changed by COVID. There was an increased predisposition to clotting. Subsequently, now it's very difficult to correlate with COVID. And I personally don't think that any vaccine or any such things, they are quite controversial topics. So I don't think any of these. COVID vaccines saved thousands of people. So to blame that this particular COVID vaccine, this was responsible for increased heart attacks, is unfair. So scientifically thinking, I think what is the summary of your question is that we should avoid extremes.
So while we were talking about celebrities, a lot of them do appear fit on the surface, right? So are we missing risk because we still rely on few visible factors, the factors that are visible to us?
Very true. The problem is that there is no 1, 2 or 3 factors that we can say. What we are generally following are the CSI guidelines, the European guidelines or the American guidelines for diagnosing heart disease. We get their cholesterol checked. We find that the cholesterol is high. There are some genetic factors like lipoprotein A, there is some homocysteine, there all those things. They tell us that this XYZ has more chance of having a heart attack than a person whose levels are normal. Unfortunately, there is not a direct correlation. That supposing if you have a LDL cholesterol of 150, you will get a heart attack after 3 months. No, nothing like that. So you can have a heart attack at the LDL cholesterol of 60 also. But the possibility of a person having genetic dyslipidemia, which can be picked up by some of the tests, do help. Now, there is something which has been widely propagated by a lot of cardiologists and cardiac surgeons, is the use of the coronary CT, either the calcium score or to pick up blockages. But these can never be mass screening tools. You cannot have them as tools for the entire society. These can be only for people whom you can pinpoint that this particular gentleman has, because of strong family history, a possibility that he might be having symptoms which are, or he might be predisposed to having a heart attack in the future. But again I emphasize that heart disease is no astrology. Nobody can predict. Even 10 minutes before a person gets an event, he's fine. He's doing everything which anybody else is doing. So it is very difficult to predict. You can't label it on anything. And then another question which I'm sure you must be having in your sleeve is, can AI predict this? So again, that too is conjecture as of now. But there are certain markers which have been picked up. Like there are some genetic factors. There are some factors such as if you smoke, you might have more incidence or you might have less incidence of heart disease. But again, these are all conjecture. There is not much scientific evidence that these can actually predict that X, Y, Z will have a heart attack at the age of 50 or 40. So as of now, science is not able to predict how and at what time the person will have a heart attack.
Talk to us from a cardiology lens. Where are we falling short?
We just discussed that basically these health checkups give us levels, like it tells us how much is the cholesterol, are you a diabetic, are you having high lipoprotein A, are you having high homocysteine. These are all factors which can increase the risk of heart disease. But again, routine health checkups, again, it's very difficult to predict, but of course it will help us in picking up people with hereditary dyslipidemias. That means people with hereditary cholesterol disorders. So once we are able to pick these people up, then intensive therapy, like if we pick up, then first is intensive therapy, then we can pick up families. Like if X has LDL cholesterol of 190, we regard LDL cholesterol below 70 as good. Below 100 is okay, but below 70 is good. So if there is LDL cholesterol of 190, we know this patient is going to be genetically prone to heart disease. We can screen his family, we can screen his brothers and sisters and his future generations, and we can find out how much is the incidence there and what is the possibility of controlling this disease by bringing these levels down. And bringing these levels down involve three things. One is lifestyle, which is physical exercise. Second is diet, control of diet. But in hereditary dyslipidemias, which we inherit, it is a genetic defect in the liver. That is why LDL cholesterol. So if no amount of stopping ghee, makhan, tala hua is going to help. It is, you have to be on medication to bring down bad cholesterol. There is unfortunately a very negative campaign against cholesterol medicines, that they lead to various side effects. There is a feeling that they can give rise to muscle disorders and all. The number of people who have been saved by these cholesterol medicines is phenomenal. All guidelines the world over acknowledge this, and especially in our country. In our country, we have two guidelines, the Cardiology Society of India guidelines, the Lipid Association of India guidelines. Both these guidelines are very stringent, and because they acknowledge that in a population in which there is high bad cholesterol, the incidence of heart problem is far higher. So the purpose of these executive health checkups is that we will be able to pick up these individuals and treat them. We'll be able to pick up pre-diabetics. Supposing we are able to pick up a pre-diabetic, we can treat that. So we can pick up metabolic syndromes, which we were discussing earlier. The Indian genetic phenotype. So this is the advantages of routine screening. But as I mentioned again, basically these screenings can be maybe done in a corporate setup, but these can never be mass public campaigns. You can't do a screening of the entire population. It's just not possible. Our country is
even if there is
big.
awareness.
Even if there is awareness.
Yeah.
Even if there is awareness. But again, if we are able to pick up hereditary diseases, then we are able to treat them and prevent several future episodes.
Yeah. For example, lipoprotein that you were talking about. So that is linked to genetic.
Yes, lipoprotein A is a factor which increases the atherogenicity of LDL. It should be done once in a lifetime for everybody. Then we know that this level is high. Then the LDL needs to be more stringently brought down. A person with a high LPA, see, the normal levels usually in most labs are 30. A person with a LPA level of 100, we know will be far more predisposed to heart problems than with an LPA level of 3 or 4. So they need to be intensively treated once we detect that the LPA is high. Unfortunately, as of now, there are various trials which are going on, and hopefully by 2027 or 28, we will have specific drugs targeting LPA. As of now, we don't have. So once we get that, maybe our outlook for treating cholesterol will be
more evolved.
We'll be better off.
Yeah. All right. So, doctor, how do you think the profile of a typical, cardiac patient has fundamentally changed over the years now?
See, when I was in GB Pant about 30 years back, at that time, the heart disease, or maybe even earlier, was basically a disease of 60s, 70s and 80s. The Indian population, the aging population was getting these.
They were more prone to it.
They were more prone to it. At that time, the younger people were probably had better lifestyle, they were exercising, they were eating less junk food, smoking was less, alcoholism was less, and we didn't have a mobile, so we were probably mobile. So all these things were helping us. So now the current profile is that a person particularly is a very busy executive, about 35, 40, 45, who is sedentary, who eats in his office, he takes pizzas and burgers, he smokes whenever he is stressed, and virtually every night he takes alcohol. So this is the typical phenotype, the typical population that is coming to us with heart disease now.
So is there a case for tiered screening or tired screening in this case, like basic versus advanced, depending on the patient profile?
Yes, that is what we were discussing. Once we find out if we have a basic screening and we find that this person has a high LDL, he smokes, he has a sedentary lifestyle, so we know his chances of predicting, there are various markers which predict that the possibility of having a heart disease is higher. Then they can be subjected to first a calcium score, which is done by CT. Second is using a CT coronary, which will tell us this XY gentleman has 50% blockages at the age of 40. So we can have intensive therapy to sort of limit the disease at 40% and make it more stable. Why does a person who has a stable disease become prone to having a acute coronary syndrome? Acute coronary syndrome is a type of heart attack. It's because the stable disease becomes unstable. The plaques which are there in the coronary arteries, you might be having, I might be having, everyone here would be having some plaques. But they are stable. They are not going to bother us maybe the entire lifestyle if we are careful. But if we have that particular phenotype which we discussed, then these plaques rupture and these obstruct the coronary arteries, and these are the people who are prone. So once if we do a screening by a CT angio, we know this gentleman can get it. So we can put him on intensive therapy.
So, Dr. Passey, before moving on to the diagnostics part of cardiology, talk to us about at what age, in your view, or is there any age you think should Indians, start with structured cardiovascular risk assessment?
There is a lot of thought on that. There is a lobby which is suggesting that as early as maybe 13, 14, 15 years, we should do a lipid profile and try to pick up people who are genetically prone. It's not very practical, but there is a lobby which is suggesting that early detection prevents future events. So there is actually no age, but what can be done is that as we discussed, that people in maybe a corporate setup, doctors are prone to so many heart attacks. We have treated over the past year several heart doctors who had heart problems. So this all who are having a stressful lifestyle, overexertion, lack of sleep, lack of relaxation, all these people are prone to have heart problems. So doctors is one of the top as far as this is concerned.
Dr. Passey, let's start with the diagnostics part now. What has evolved and where we are still stuck? So starting with how much has cardiac screening technology evolved over the past few years as per you?
We just discussed some of these aspects. One is screening via the blood tests. The second is what we have been doing traditionally is subjecting these patients to stress test. Like they go for a TMT, or they go for a stress echo or a stress thallium or some of these investigations. But by and large, they are not applicable to society as a whole. Plus, there are the number of false positives and false negatives. The positive predictive value, the negative predictive value of these tests are suspect. So they cannot be mass screening tools. What I just mentioned is that we can go for a calcium score or a CT coronary angio, which probably, if we know that a certain gentleman has that particular phenotype we discussed, so this is the screening tool which can be advocated for that.
All right. So, doctor, in my research, I found there are a few tests like CT coronary angiography.
We just discussed.
Yeah, calcium scoring
We
is
just discussed.
yeah. So are these becoming mainstream, or they are still limited to to select centers or select hospitals?
No, they are becoming. Of course, they are still less than what we desire, but that can't be held. Ours is the world's most populated country. So, but there are several centers. Maybe 15 years, 20 years, we could get these tests at 5 or 7 centers or 10 centers in Delhi. Now there will be approximately 300-400, maybe even 1,000, maybe even more than that. So now the mass reach is, the only thing is that quality control is something which is lacking. We at times find reports of calcium score or of CT of the heart, CT coronaries, which don't match with the angiography which we actually perform when we put the catheter. There is a learning curve, or maybe the competence is not there as far as mass screening is concerned. But it is picking up, and now these tools are available. But of course, the limitation is that they are available in type A or type 2 type, in the metros or the bigger cities. They won't be available.
In tier 2 cities or tier 3
in the
cities?
tier 2 cities, maybe we can have, but not so much in smaller towns or villages. That is very unlikely.
Yeah, so there is an availability of advanced diagnostics.
Yes,
when we talk
now
about
they are
this.
available,
Now
yes.
they are available. Yes, but do you find any gap between when we talk about the actual utilization of these advanced technologies?
Now as I mentioned, the usage has become far more. In our hospital only, the screening used to be of a very few patients, as I mentioned some years back. Now several patients are being screened. So the usage is becoming more common as the awareness spreads.
So what are those more precise tools now that exist apart from, of course, ECG, TMT? What are those other tools?
The tools are, as we mentioned, you had read some. Can I know?
No, I want to know it from you.
This is the CT and CT coronary. These are the documented tools. But besides heart blockage disease, there are some other tools to pick up various other heart diseases. Like a person having high BP starts getting the wall of the left ventricle thickens. So that can be picked up by an instrument known as echocardiography. They can be picked up by MRI. So various other heart diseases which coexist or can be separate from blockages, they can be picked up by screening tools like echo and MRI, and which are also now available.
Yeah, we were also talking about lipid markers. What is biomarker? First, let's talk about that, and where does it fit?
Biomarkers are markers for if a person has had a chest pain, he presents to the emergency, then we do certain biomarkers like the troponin, CPK, CPK-MB, and these are all tests which tell us if there is any myocardial necrosis. That means, is the heart muscle getting compromised? Because if there is a reduction in blood supply, the heart muscle starts getting damaged, and these biomarkers are released in the blood within the first 2 hours, 3 hours, 4 hours of a chest pain. And if we are able to pick them up, then we know that this person is prone to having a heart problem and would need hospitalization and further treatment. The further treatment can be medicines, it can be an angiography, an angioplasty or bypass surgery, depending on the severity of disease.
In the beginning, doctor, you also mentioned about AI, how we are still not there yet. So we haven't seen any real, use cases as of now as we speak about AI at this point in time.
See, as I mentioned, AI helps us in maybe giving a more precise diagnosis. We mentioned about there are some errors being picked up in CT coronaries. So AI helps us in getting a more precise diagnosis. I am not aware that AI is able to predict that X is okay today and 10 years hence is going to get a heart attack. Even though several commercial units have started advertising that we can predict this is going to
Early
happen.
risk prediction,
If you're going to get a cancer, if you're going to get heart disease. But I personally believe they are still very primitive. They have not reached that level to be able to precisely predict.
Yeah, so they are still not the game changers.
No, certainly not. Not as of now.
Not as of now. Of course, AI is evolving day by day.
Yes. So maybe 5 years and all. There are several things which we are doing now which we never thought could be possible 10 years back.
So when we talk about the OPD level decision making, like how much have you integrated AI, or still there is no AI in terms of that decision making?
AI, it may be not in decision making. AI is now being used for giving, for assimilating data like the patient's investigations, and then we have our system by which the data can be analyzed and we can come to a diagnosis, or we can store data. But AI, again, as I said, not for prediction.
All right, so what's the biggest issue? Like, are the technologies still not there, or is there a clinical trust that hasn't been developed yet? What is the biggest barrier you are seeing?
See, AI actually is now being used by patients, by general population, for self-diagnosis. So that is the problem. Self-diagnosis based on 1, 2, 3 is not going to correlate with what could be a reality. So AI, there are uses, there are misuses. So as of now, I don't think AI is able to predict, as we discussed, that X is going to have a heart attack after 10 years. It's not.
So there is no
possible.
Early risk prediction through AI.
No, there is. There are factors which they pick up, like genetic and all, but they are not 100%. See, human body is very variable. How X will respond to a certain treatment is different from how Y is going to respond. This is true for all aspects of medicine. An anti-cancer drug in one patient works wonders. In the similar patient with a similar diagnosis, it does nothing. So all this is, human body is so variable, so difficult to understand, nothing can be predicted. So it is best not. So how clinicians work is by putting 2 plus 2 together and making 4. To expect 2 plus 2 to become 6 or 5 or 10 is not possible in human body.
But has these technologies or have these technologies helped in the turnaround time in diagnostics?
Yes, definitely. Definitely, because now say maybe a radiologist is able to read at home the X-rays, and there are and of course we have remote or robotic techniques which are available. So things have become much better. Technology is definitely welcome and it is helping us.
All right, so doctor, now let's move to the treatment evolution, how the treatment has evolved over the years and what's actually changing now. So when we talk about interventional cardiology, it has sort of advanced rapidly, but what are the biggest shifts you have seen in your career in the procedures?
Yes, that's a very relevant question. See, when we started doing angioplasties about say 25 to 30 years back, everything was dependent on what we saw on the screen. We used to put the catheter inside, we used to see that this is the blockage, and we used to treat the blockage as it was. Now we have various techniques that we can really enter the artery itself by using intravascular ultrasound or optical coherence tomography, OCT. This is one of the biggest advances that we have in science today in coronary artery disease. We are able to see what sort of blockage. We had discussed earlier that there are some vulnerable plaques, some plaques which are more prone to rupture and cause heart attacks. We can actually pick them up. They are hotter than the rest of the environment inside. So we are able to pick up that this particular plaque, this particular thing can give rise to a problem in the future. So this is where technology is helping us now. The diagnostic as well as the treatment aspects. Now we have several techniques like maybe even 15 years back, a person with very hard calcium in his heart arteries, like a solid rock inside. And we could not open it by drilling, by so many techniques. Now we have lithotripsy, which is being used for stones in the kidneys. We can break the calcium inside the heart arteries. We can melt it up and open the arteries and subsequently treat. This is one aspect. So just like that, we have several techniques which are now, we have some very high pressure balloons which are able to give us much bigger diameters than we were having earlier. So evolution of intervention cardiology has been significant, both as far as diagnostic as well as treatment is concerned. The quality of stents that we have, now a new concept has come that we don't need to stent. We just put in the drug into the arteries and leave the arteries without stents. The biggest advantage is that blood thinning medicines are usually not required long term for these patients. So this is a technology, we call it stentless angioplasty. So which has evolved and which is now being widely practiced, and we are practicing in Ganga Ram Hospital for last 4 or 5 years now.
Alright, so when we talk about minimally invasive procedures, they have now become default, are we still relying on, patient profile and also affordability for that matter?
Yeah, I think minimally invasive procedures are more applicable for surgical branches, not so much in cardiology, like for gallstone disease. Everybody goes for a laparoscopic cholecystectomy. Nobody goes for open cholecystectomy now. So obviously the availability has become better, and almost all centers, even in small towns, are doing these. And with the widespread availability, the cost has come down. So all these techniques are available. Minimally invasive procedures are being performed, not so much in intervention cardiology, maybe in cardiac surgery and other surgical branches.
Yeah. So doctor, you were also talking about the stunt technology, how it has evolved. So has it changed the long-term outcomes also meaningfully now for us?
As I mentioned, that we are doing a lot of cases of stentless angioplasty. When we don't put in a stent at all, the stent is a metal which has a drug coat inside. We implant it into the vessel, so we create a new pipe, and the pipe has metal inside. What we are doing now is we open the artery, we make it smooth by using a cutting balloon or a scoring balloon, and then we implant the drug directly onto the vessel wall, and so no metal is left behind. So this is one evolution of angioplasty which has taken place. The biggest advantage is that they don't need blood thinning medicines in the long term. It's a normal physiological, the patient's own arteries are still functional. The drug is implanted and the drug disappears within a few days to weeks. And then the patient remains stable after that. And now the results of these technologies are better than the stents which we were using, say, 20 years back.
Alright, so are these like treatment plans, they are still more protocol driven or personalized?
No, they are protocol driven. You have to, in respectable centers, they are all protocol driven. They are all guided by guidelines which are issued by the various bodies like the American College of Cardiology, the European Heart Society. These are all giving various guidelines and we all follow them.
Alright, so now doctor, let's move to another segment on remote monitoring and also the continuity of care. Starting with the remote cardiac monitoring, or as I can see, it is also called telecardiology. Yeah. So are these actually improving outcomes?
See,
or just improving process?
There are two aspects of this. One is telemonitoring via the smartwatches, which has only resulted in more patients for us. Because most of the people, when they see the watch, like our friend there, they all will see that something is going wrong and then they'll rush to cardiologist or to physicians. Actually, that is not remote monitoring. That is, it's a misnomer. Remote monitoring is a scientific way of doing it. There are various monitors which are available. They are implanted externally. We have a loop recorder or a external or Holter, or which are implanted. They are small devices on the chest, and they pick up any irregularity in rhythm. We can even remotely monitor blood pressure. We can remotely monitor heart beating. We can pick up if there is a heart rhythm disorder. This is how technology is. So rather than depending on smartwatches, if a person has suspicion of having a heart rhythm problem, then he needs a scientific way to do it. And now there is wide acceptance and availability of various devices to do that. And we are able to say, I have a patient somewhere in Bombay or in Calcutta or in Madras. He's wearing a device. I'll come to know that if he gets an arrhythmia.
Okay.
This is also applicable for various pacemakers that we put. They can we can remotely monitor them, and we can find out if the person is developing any issue which is abnormal. So this is an evolution of technology which is available and which is being widely used in all good centers in our country.
Yeah, but while you were talking about smartwatches, a lot of people do use smartwatches.
So as I said, that has resulted in
a
us
lot
having
of patients.
More patients.
Yeah, but all the data, the wearable data that has been collected, has it ever helped you in any of the decision making?
At times it does, because then if a patient is smart enough, then he goes and gets an ECG done immediately, or if he is able to pick up. But more often than not, these are false alarms. So if we are able to get maybe 10-15% accurate results, 80% are false alarms.
All right. So do you also see, while we are talking about cardiac patients, do you also see hospitals building post-discharge monitoring ecosystems?
Yes.
How are we doing that?
Most of these hospitals have facility of reaching out. Reaching out means when the patient gets discharged, they can have monitors at home which can be communicated with their treating doctors, or they can actually have devices at home by which various parameters and all are monitored. This is being done, but of course it's costly. It's not possible for everybody to get it, and there is a very select population which actually needs it, like heart failure patients. Heart failure means that the pumping of the heart is low and the patient gets breathless because of fluid accumulation. So this can be monitored at home by various techniques which are available. So the patient can rush to the hospital or can seek medical care if he is able to pick it up faster.
All right, so let's talk about you also as a cardiologist. As a cardiologist, are they today, or are you today expected to be more tech savvy than before?
Of course, otherwise I can't survive. Of course.
So the job market is changing for you as well?
Job market certainly is, maybe the younger cardiologists who are coming now, they need it more than probably us, but of course, if we have to survive, we have to be up to date with whatever is going on. Yeah. That is what CMEs and various programs are about.
So, but do you see a skill gap between the technicians and clinicians still?
I think the gap is closing. The technical awareness is getting better, and the gap is closing.
Right. So now, as we are closing this podcast, there's one segment which is perhaps very important for us, which is the ecosystem of so that we can perhaps talk about this in entirety. Let's start with how cardiac care in India is becoming expensive. What do you think? It's becoming more expensive. It is not for everyone. Like we discussed a few pointers in the course of our discussion. But how do you see it currently in Indian scenario?
See, actually, healthcare in India currently is, you remember COVID?
Yeah.
COVID, the private sector paid a very important part. We were among the best in the world, mainly because hospitals stopped everything else. They filled up COVID patients who were treated I'm not saying everyone survived, but we were much better off than some of the European countries, maybe even the US. So the thrust now is in the private sector, or a sort of a semi-government private mix sector. If we there is one extreme, which is the corporates. The second is like our hospital, which is a charity-based hospital or a trust-run hospital, which has no owner. The trust, the money what we earn from the hospital is put into the trust, and the trust supports newer advancements. So we are able to, in our hospital, offer healthcare at much less prices, much less rates than anywhere in the private sector. So it's a public-private partnership sort of thing, which can ultimately be the answer as far as your question is concerned.
Yeah, for scaling the cardiac care infrastructure.
Yes, that will help in bringing down the prices. A few years back, the government took a very bold decision of restricting the prices of various instruments, like stents and other things which are, and it has really helped in and plus we are getting so much indigenous production of various stents, valves, the transaortic valve implantation, which is now being carried out, and Indian companies are manufacturing. So the cost has come down. I foresee that it will come down further. The availability will be more, the cost will come down, and we are now widely regarded as one of the centers where from all over the world people are coming for treatment. So, and not just that, at Ganga Ram we get a lot of patients from Bihar, from Eastern UP, from so many places.
All the tier 2 and tier 3 cities as well.
Yeah, so they know that the healthcare is of best quality and at a reasonable rate.
Yeah, but they do have to travel from their states to come here for healthcare. So there is still a gap.
Yeah, that is true. But again, centers are opening up all over the country.
And is the technology reaching there?
30 years back, we had, or 28 years back, we had maybe 150 centers doing angioplasty. Now we have several lakh centers doing angioplasty all over the country. So this is the difference. We have a teaching program. Our students go to all are there in Uttaranchal, in Himachal, in so many, in Rajasthan, in remote areas. So many of our students are doing angioplasties there. So it is something which is evolving, and the government private partnership has helped in evolution.
All right, doctor, we are closing with the last segment, which is the reality check, right? So very short answers for this, because we spoke a lot about tech throughout our conversation. Let's start with the first question. Do you feel is there a risk of overdiagnosis or over-intervention because of the technology coming in? We of course discussed in terms of smartwatches, but are there any other?
Yes, that is always there. A lot of people who probably can be managed by just medicines or don't need anything, they are subjected to various procedures which might not be essential. So this is a reality. So this is something which has to come from an individual. It's your own consciousness. It's your own thought process. You have to be true to yourself. You have to think when you are treating a patient that this patient can be my father, my mother, my brother, my sister. If you have that feeling, then it will not go wrong. But if you have a feeling that this patient is going to get me money, then things will go wrong. It's as simple as that.
No, of course. So, what's one technology as per you, or one technology trend in cardiology that you think is overhyped right now?
Overhyped as far as, see again,
you spoke about AI, I know that AI is a bit overhyped right now, but is there anything else?
There are certain procedures which are being carried out, as I mentioned, where maybe a surgical option is a better or maybe nothing. So this is something which is widely prevalent, and there are several issues like moral issues in this. So it's difficult to really quantify them or to say that X, Y, Z is responsible. It's possibly the degeneration in society which contributes to this.
Yeah, and that is perhaps another issue to discuss on some another podcast, because it will
Of
take a 1 hour episode. One technology trend or one trend in cardiac care that you genuinely believe is going to change outcomes for India in the coming future?
Which we discussed, the treatment of lipids, which is now a widespread awareness. I'll give an example. A friend of mine, he used to get my classmate from school, he used to get his cholesterol done every year. His cholesterol was very high, but he never took any treatment. Ultimately, he landed with me with a lot of problem. His cholesterol was very high. He underwent a bypass surgery. So this is a classical example of getting a test done but not taking treatment. So this is one aspect of treatment which is going to change if we are able to make people understand that treating cholesterol, treating bad cholesterol is going to change outcomes dramatically in Indian population. So this is something which holds a lot of promise for the future.
All right. One last question, doctor. Keeping in mind your years of experience in this particular, vertical, if you had to design the ideal cardiac care model for India, how would you design that in terms of course, prevention, diagnosis, and also treatment?
I think something which I would like to bring out from our own department in Ganga Ram Hospital. We have a department in which all the cardiologists work together. We have a preventive aspect, we have an intervention group, we have a group looking after echo, we have a group looking after patient care. So all of us together work towards one common goal, that we need to get patients to do well. So this is the sort of practice which should be advocated everywhere. Rather than having cutthroat competition, if it is a cohesive work model, which includes early diagnosis, early treatment, and good long-term outcomes. This is what would be an ideal model.
All right, Dr. Passey, thank you so much. And this is where we would like to close our podcast. And perhaps we have a lot to talk about in the next episode, whenever you give time to us.
Sure. Thank you, Hemanshi, for having me here.
Thank you so much. And to our viewers, stay tuned for many, many more such interesting conversations as we bring you the ecosystem of healthcare, be it doctors, hospital CEOs, wellness chains, gyms, and everyone who are involved in the ecosystems directly to you at ET Health World.